Hi everyone, and welcome to our module on hypertension in pregnancy. When women develop high blood pressure in pregnancy, we classify them into one of three groups. Women are considered to have pre-existing or chronic hypertension if they develop high blood pressure before they become pregnant or during early pregnancy before 20 weeks. Basically, the placenta and other factors related to pregnancy can cause hypertension, but it takes up to 20 weeks for that to occur. So in any woman who has high blood pressure, either before she's pregnant or before 20 weeks, that woman does not have gestational hypertension. She has pre-existing or the usual chronic hypertension that you see in non-pregnant patients. In contrast, when hypertension develops after 20 weeks of pregnancy, that's what's called gestational hypertension, and that's what we'll talk about in this video. And then finally, preeclampsia is a subtype of hypertension in pregnancy where women also develop proteinuria and end organ damage. And these are potentially life-threatening conditions to the mother and the baby, and we'll talk about this in this video later as well. One of the main reasons that hypertension is bad during pregnancy is because when the blood pressure is high, it decreases the perfusion to the placenta. So there's an increased risk of adverse fetal outcomes. There can be fetal growth restriction, there can be oligohydramnios, and the placenta can basically be unhealthy, and this can lead to placental abruption. When a woman develops hypertension in pregnancy, the workup involves screening for elements of preeclampsia or eclampsia. So in preeclampsia, there's proteinuria. So in any woman who is hypertensive in pregnancy, you need to check for urine protein. And then we'll talk later about how in severe cases of preeclampsia or eclampsia, the CBC, the renal function test, the liver function test, or the coags can all become abnormal. So in any woman who develops hypertension in pregnancy, you want to check these things to establish a baseline. And then lastly, it's long been described that hyperuricemia is very common in preeclampsia. So many obstetricians measure a uric acid in women who have high blood pressure. If it's high, it's not diagnostic of preeclampsia, but it suggests a patient that is more likely to develop it later on. In terms of management, hypertension in pregnancy usually isn't treated unless the blood pressure is over 160 systolic or 110 diastolic. For milder degrees of hypertension, usually this is just monitored during the pregnancy. One of the drugs you'll most commonly see used in women who are pregnant with hypertension is labetalol. It's a combination beta and alpha blocking drug that can be used in pregnancy and is relatively safe. Another option is nifedipine, which is a calcium channel blocker. And then sort of the old standard drug for hypertension in pregnancy is alpha-methyl-dopa. This drug is not very potent, so it doesn't tend to work very well to lower the blood pressure, but this is the oldest drug with the most safety data on it for use during pregnancy. And then importantly, in any woman who is pregnant, you want to avoid treating her with ACE inhibitors or angiotensin receptor blockers. I talk about these drugs in videos on teratogens, but they're both dangerous to the baby. Rarely, mothers who have hypertension in pregnancy can present with a hypertensive crisis. I talk about hypertensive crisis in videos in the cardiology section, but it can sometimes present in women who are pregnant. When this happens, usually intravenous drugs are used to rapidly lower the blood pressure from dangerously high levels. One of the most commonly used drugs here is labetalol. Just like it can be given orally to women who are pregnant, it can also be used intravenously for women who have hypertensive crisis. One of its side effects is that it can cause bradycardia in either the mother or the baby because it's a beta blocker. Beyond labetalol, there's an intravenous form of hydralazine that can be used. This is often the go-to drug if bradycardia is present and the mother can't tolerate labetalol. And then beyond these two intravenous drugs, oral nifedipine is very effective at bringing down blood pressure from high levels. So often this will be given together with the intravenous drugs in hopes that you can wean the intravenous drugs off over time. Let's talk about delivery of the baby in women who have gestational hypertension. If the blood pressures are poorly controlled, and the definition of poorly controlled is generally greater than 160 over 110, this is a group of women in whom there is a very high risk of fetal loss. So if these women are remote from term, then they're usually hospitalized until delivery, and there's frequent fetal surveillance done with ultrasound, and this usually drives delivery. The ACOG guidelines recommend delivery at equal to or greater than 34 weeks, but really it ultimately depends on the fetal surveillance and how well the baby is doing. For women in whom the blood pressure is controlled and consistently less than 160 over 110, these women can deliver at term. Okay, moving on, let's talk about preeclampsia. This is a multi-system disorder of pregnancy. It always involves pregnancy-associated hypertension, but it also involves renal problems with protein in the urine and end organ dysfunction, and we'll talk about what I mean by this in just a minute. In terms of the pathogenesis of preeclampsia, the thing you want to always remember is that it's a disorder that's caused by the placenta. Preeclampsia is thought to develop because of abnormal invasion and transformation of the spiral arteries of the uterus. And when these arteries don't develop normally in pregnancy, that leads to chronic underperfusion of the placenta. When this happens, the placenta responds by releasing circulating substances that cause diffuse endothelial dysfunction in the mother's vascular system. So basically, because of the problem in the placenta, throughout the mother's body there is vasospasm and coagulation going on, and that's what causes the clinical features of preeclampsia. And if you know that this is a disorder of the placenta, then it's easy to remember that it's going to resolve with delivery. When you remove the placenta, the mother is going to get better. So if you can safely deliver the baby and remove the placenta, the clinical features of preeclampsia should resolve. In terms of clinical features, the first thing to know about preeclampsia is that the onset usually occurs in the third trimester. And the first element of preeclampsia is new onset hypertension. This is usually going to be in a mother with no known history of hypertension. She will develop in the third trimester a systolic pressure greater than 140 and/or a diastolic over 90. The second element of preeclampsia is proteinuria, and there are a couple of definitions of proteinuria that are used in preeclampsia. The first one is a 24-hour urine collection showing greater than 300 milligrams of protein in the urine. Another way to meet the definition is to have a urine protein to creatinine ratio of greater than 0.3. And then finally, a dipstick reading of 2+ or greater protein meets the definition of proteinuria for preeclampsia. Importantly, if the dipstick shows 1+ protein in the urine, you need to confirm this with one of these two other measurements. 1+ proteinuria is not enough to meet the definition of proteinuria for preeclampsia. And then the final element of preeclampsia is evidence of end organ damage. This could be renal failure, which occurs from vasospasm of renal vessels. It could be CNS disturbances, things like headaches or visual changes or confusion, or it could be evidence of liver failure. So a woman in the third trimester who has all three of these things shown on this slide meets the definition of preeclampsia. Preeclampsia often presents with severe lower extremity pitting edema. The reason this happens is because when protein is lost in the urine, this lowers the oncotic pressure. This causes fluid to leak out of capillaries. As that happens, there's more salt and water retention. So all of this works together to cause severe edema. And when I was in medical school, I was taught that preeclampsia was the triad of hypertension, proteinuria, and edema. This definition has fallen out of favor because all pregnant women have some degree of edema from compression of venous return due to the fetus. But it's still helpful, I think, for clinical practice to know that severe edema is often what you'll see in women who have preeclampsia. Preeclampsia often involves the liver. There can be edema of the liver. There can also be ischemia and necrosis of hepatocytes. And so for this reason, elevations of the liver enzyme tests are very common in women who have preeclampsia. There are lots of established risk factors for preeclampsia, but on this slide I've listed some of the important ones that you should know for your rotations and your boards. First of all, if a woman has had a prior pregnancy with preeclampsia, then she is at high risk. It's also high risk if a woman's at her first pregnancy. Once a woman has had one pregnancy without developing preeclampsia, then she is at lower risk. Women with a family history of preeclampsia are at higher risk, and so are pregnancies that are multiple gestations. And then lastly, there are a number of maternal conditions which, if present prior to pregnancy, raise the risk of preeclampsia. Some of these include diabetes and hypertension, also obesity and chronic kidney disease. And then any woman with lupus or the antiphospholipid syndrome is at especially high risk for preeclampsia, and this often comes up in board exams. In women who are at high risk for preeclampsia and have a number of those risk factors I showed on the last slide, they are often administered low-dose aspirin. This has been shown in clinical studies to reduce the risk of preeclampsia in high-risk patients. Unfortunately, there's no consensus definition of what represents a high-risk patient. So in women who have one or more of those risk factors shown in the last slide, many OBs will prescribe low-dose aspirin. It's initiated after 12 weeks but before 28 weeks, and the greatest benefit to the mother is if it's started before 16 weeks. And then once you start it, it's continued daily until delivery of the baby. Let's talk about some of the complications that can develop in preeclampsia. First of all, in terms of pregnancy complications, what you always want to remember is that preeclampsia is a disorder of the placenta, so it can lead to placental problems in pregnancy. This could mean placental insufficiency, which can cause things like growth restriction in the baby or oligohydramnios. Women with preeclampsia also have an increased risk of developing placental abruption. There are a number of maternal complications that can occur in women with preeclampsia as part of the end organ dysfunction element of preeclampsia. Some of the things you can see in moms who have preeclampsia include pulmonary edema and heart failure. Liver failure and DIC can also develop. Stroke is a rare but very serious complication of preeclampsia. And then because of the renal failure, some patients can end up on dialysis from preeclampsia. For your clinical rotations and your boards, you're going to want to know the definition of preeclampsia with severe features. These are clinical features that identify women who are at the highest risk of adverse outcomes from preeclampsia. The first one is a systolic pressure greater than 160 or a diastolic over 110. This has to be measured on 2 occasions at least 4 hours apart while the woman is on bed rest. Another severe feature is new cerebral or visual disturbances. So a woman with preeclampsia who complains of scotomata or visual losses, this represents severe preeclampsia. Also, a woman who has a severe headache from preeclampsia has evidence of severe features. Beyond these things, if there are elevations of the AST and ALT or if the platelets are low, this is evidence of severe preeclampsia. Also, if the woman develops renal insufficiency or pulmonary edema. The management of preeclampsia depends a lot on whether or not those severe features are present. In women who have no severe features present, they can be allowed to deliver at term, which is greater than or equal to 37 weeks, so long as the baby is healthy by ultrasound assessment. Intravenous magnesium sulfate is usually administered to prevent seizures at the time of delivery, and we'll talk more about this in a minute when we talk about eclampsia. In women who have preeclampsia with severe features, however, in these cases delivery is often considered earlier, as early as 34 weeks. Just like we talked about with hypertension, this depends largely on the health of the baby by fetal surveillance, but the point here is that when women have severe features present, often the baby needs to be delivered earlier. So now let's talk about eclampsia. The definition of eclampsia is when a mother with preeclampsia develops seizures. Usually the seizures associated with eclampsia are generalized tonic-clonic seizures, and they can potentially lead to coma and death. Often when a woman develops eclampsia, in addition to the seizures, she has features of severe preeclampsia, including things like DIC and respiratory failure. The exact etiology of the seizures is unclear. It may have to do with blood flow and endothelial dysfunction, but in general it's just considered a severe form of the organ dysfunction that you see in women who have preeclampsia. When women develop seizures and eclampsia, the anticonvulsant drug of choice is magnesium sulfate. This is the best studied and most effective drug for treating seizures in eclampsia. And as I mentioned earlier, it's often given for prevention of seizures among women who have preeclampsia. In women with preeclampsia at the time of delivery, magnesium sulfate is often administered because that's a high-risk time for development of seizures. And in terms of mechanism of action, one thing you want to know is that magnesium sulfate inhibits acetylcholine release. This can be beneficial in terms of limiting seizures, but it also can cause hyporeflexia or drowsiness. These are very common in women who receive mag sulfate. And because it inhibits acetylcholine release, it's contraindicated in myasthenia gravis, and it's high yield to know this for your boards. Patients with myasthenia gravis have neuromuscular weakness at baseline, and so if you block acetylcholine release, you can trigger a myasthenic crisis. And then besides giving magnesium sulfate, the definitive treatment for eclampsia is to deliver the baby. Remember, with both preeclampsia and eclampsia, the cause of the problem is the placenta, so if you deliver the baby and remove the placenta, the mother will usually improve. One of the potential adverse effects of magnesium sulfate is magnesium toxicity. This is rare in women who have renal function that is normal, but remember, many women with preeclampsia have abnormal renal function from preeclampsia, and so when those women receive magnesium sulfate, they are at risk for magnesium toxicity. So because of the risk of magnesium toxicity, usually a clinical assessment is done in women who receive magnesium sulfate every 1 to 2 hours. What's usually done is to check the deep tendon reflexes, because one of the earliest signs of mag toxicity is hyporeflexia. Women are also usually checked for signs of respiratory paralysis or abnormal cardiac conduction. These things can also happen from magnesium toxicity. And then in women who have renal insufficiency, at the time they're treated with magnesium sulfate, usually a serum magnesium level is obtained. The therapeutic range is 4.8 to 8.4, which is higher than the normal magnesium level range, but not high enough to cause symptoms of toxicity. And then in rare cases of severe magnesium toxicity, the antidote is calcium gluconate. This is usually reserved for cases of severe cardiac toxicity from high magnesium levels, for example, a woman who has a cardiac arrest from elevated serum magnesium. The HELP syndrome is a variant of preeclampsia. HELP is a mnemonic. H is for hemolysis, EL is for elevated liver enzymes, and LP is for low platelet count. And this is really just a complicated variant of preeclampsia. It's a severe form, It's caused by coagulation activation and liver infarction. This leads to necrosis of the liver, plus you can have hematomas and thrombi. The liver can even swell, causing right upper quadrant pain. And earlier I talked about preeclampsia with severe features, and some of those severe features are elevated liver enzymes and low platelets because those are elements of the HELLP syndrome. On peripheral blood smear, women with the HELLP syndrome have evidence of microangiopathic hemolytic anemia, so you can see schistocytes like what's shown in the slide here. These women can also develop elevated bilirubin and low haptoglobin from hemolysis. And then beyond this, these women have thrombocytopenia because platelets are being consumed. And the treatment, just like with all severe forms of preeclampsia and eclampsia, is to deliver the baby. If you do this, usually the elements of the HELLP syndrome will resolve. I'll finish with one slide on gestational thrombocytopenia. This is a benign condition that also occurs in the third trimester, just like preeclampsia. It's caused by platelet sequestration in the spleen and placenta, which lowers the platelet count into the range of 100,000 to 150,000. It's entirely asymptomatic, and so in a board question, don't be confused by this into thinking that the woman may have preeclampsia when she just has gestational thrombocytopenia. There's no treatment required, but it does have a clinical implication in that in many cases, if the platelet count is low, it precludes using an epidural for pain control at the time of labor and delivery. And then I'll leave you with this slide summarizing the 4 major disorders of hypertension in pregnancy. Remember that chronic hypertension develops before 20 weeks of gestation, whereas gestational hypertension develops after 20 weeks. Preeclampsia, eclampsia, and HELLP are all related disorders. The definition of preeclampsia is new onset hypertension plus either proteinuria or evidence of end organ damage. And then the 4th category, which is complex and I didn't talk about in this video, but you should just be aware that it exists, is that preeclampsia can develop superimposed upon a woman who has chronic hypertension. And that concludes our module on hypertension in pregnancy.